my slides are moving. Please confirm. Are they moving?
Yes, yes, Manish.
Okay. Thank you. Thank you, sir. So, QI is a quality and accreditation institute. This is India's second largest accreditation body, and our founder and CEO is Dr. Bhupender Kumar Rana. He is having over 25 years of experience in quality, standard development, accreditation, and patient safety. Earlier, he worked with the NABH as a director and CEO in charge, Quality Council of India, where his visionary leadership transformed the healthcare quality framework in the country. He's a founding member of International Academy of Quality and Safety, member of Scientific Advisory Board, International Alliance of Patient Organizations, Vice Chairman of Mutual Recognition Arrangement MRA, Council of Asia Pacific Accreditation Corporation APEC, former board member and chairman of the Accreditation Council of International Society for Quality in Healthcare, ISQA. He's an international expert of the World Health Organization (WHO) and the World Bank, Asian Development Bank, and the United Nations Framework Convention on the Climate Change (UNFCCC). So, as I mentioned, we are the India's second largest accreditation body, and QI having some vision, values, and visions. So, we have vision to nurturing the largest global polar organizations and people through quality improvement and accreditation framework. We have some values. We are good listeners. We always seek continuous feedback from the stakeholders, whatever they have concerns. So we try to address their concerns. We are competitive. We look for viable options to benefit users of our services. And QI has adopted transparency because whatever our policy which are made by QI, they all are available in public domain. We are innovative. We continuously evolve using co-design and co-creations. Innovation in terms of we have developed more than 22 of number of standards in healthcare as per the healthcare facility requirements. So KI having a mission to conceive, deliver education, training, accreditation, and analytic program in partnership with various stakeholders using an approach of co-design and co-creations. So QI started its operation in August 2017, and we are APEC ILAC MRA signatory for medical testing as per the ISO 15189 for the medical testing and for the testing and calibration as per the ISO 17025. So QI having a four verticals, Center for Education and Training CET, under which we do offer various kind of training as per the ISO standard or healthcare standards. Then we have CHSC Center for Accreditation of Health Social Care, under which we do offer accreditation for the healthcare facility providers. Then CIA, under which Center for International Accreditation, we do offer accreditation as per the ISO standard, whether it could be ISO 15189, 17025, 17043, 17034, or 17020 standard. Then Center for Accreditation of Veterinary Facilities, under which we offer accreditation for the veterinary service providers. So let's thoroughly go our program, Center for International Accreditation, under which we offer accreditation for the medical laboratories as per the ISO 15189 standard. We also do offer accreditation for the testing and calibration laboratory as per the 17025 standards. We also do offer a certification for medical laboratories as per the requirement of Central Clinical Establishment Act. So we become the first body in India, those who offer accreditation for the biobanking as per the ISO 2038 standard. We also do offer accreditation for the inspection bodies as per the ISO IC 17020 standard. We also do offer accreditation for the proficiency testing provider as per the ISO IC 17043 standard. We do offer accreditation for the reference material producer as per the ISO 17034 standard. For CIA program, we have international recognition. QIA CIA is a full member MRA signatory of Asia Pacific Corporation APEC. We also full member MRA signatory of the International Laboratory Accreditation Corporation ILAC. APEC and ILAC, these are the global body, those authorize any of the accreditation body in the world. So any accreditation body can give accreditation further. So CIA program, we have our CIA program is accepted by Bureau of Indian Standard (BIS), Eastern Railway, Central Public Work Department, Director General of Quality Assurance, Power Finance Corporation, Coal India Limited, Legal Metrology Department of Consumer Affairs, and National Highway Authority of India. Military Engineering Services, Power Grid Corporation of India, Bureau of Energy Efficiency, Rights Limited, Public Works Department, MP Government, BL Bhopal, Directed Urban Administration and Development, MP Bhopal, and National Building Construction Corporation. So these are the under CIA program. These are the accredited labs under various testing, medical calibration, biobank, and PTP and RMP and inspection bodies. So we have another vertical, as I earlier mentioned, CHSC, under which we offer accreditation for the medical transport organization, ambulance services, telehealth, home healthcare, pre-hospital, dialysis center, green healthcare facility, clinics, ambulatory care, emergency department, hospital, stroke center, vision centers, hair transplant, HCT facilities, and art and IVF centers. So recently, ISO has developed one more standard for healthcare facility, which is ISO 711. So QI has adopted this as a QI 711 plus. So these are the accreditation given by QI so far. So totally 8 years of operations, QI have total number of accreditation for the healthcare facilities. So CHSC program, we become first accreditation body in India to achieve SCI accreditation, less than 5 years of operations. And we are the one and only accreditation body in India having two standard accredited by ISO. So our CHSC program is recognized by Central Government Health Scheme CGHS for empanelment of private hospital, eye centers, dental centers, and imaging centers. We are also an institutional member of International Society for Quality in Healthcare. This is a golden seal of quality accreditation mark, which are given to the any testing or medical lab, those who successfully complete QA accreditation process. We have presence globally, not only limited to India. We have presence in Bahrain, Bangladesh, Ghana, Maldives, Mongolia, Morocco, Myanmar, Nepal, Qatar, Lebanon, Bhutan, UAE. So these lab or healthcare facilities, they all are already accredited by QI. So our today webinar will take care by Dr. Ramaswamy. He is an MD Pathology. He's a professor in HOD Department of Pathology in PS Medical College, Kuppam, Andhra Pradesh. Earlier, he has been associated with Lifeline Hospital, Salah Sultan of Oman. And he is assessor with QI in CIA accreditation. He is a laboratory director, PSIMSR, Central Laboratory, Kuppam. Organizing chairperson, virtual midterm CME 2021 and IAPM chapter. So thank you. This is all about QI and our today's speaker. So I welcome Dr. Ramaswamy sir to take further.
Thank you, Manish. Thank you for your kind introduction. Can I share my screen?
Yes, sir.
Is my screen visible?
Yes, sir, visible.
Yes. Good evening, everybody. I'm Dr. Ramaswamy. I'm Professor HOD of Pathology at PES Institute of Medical Sciences and Research, Kuppam, and I bring greetings to all of you from this part of the country in India. And I thank UAI for giving me this opportunity to speak to you all on the identifying and assessing and mitigating risks in medical laboratories, the tools and the techniques. So the objectives for today's session is one, we would understand what is risk management, and we would like to understand its relationship with the two ISO standards, that is 15189 and the 22367. We'll try to look at various steps in the risk management. We'll understand what is risk mitigation and control and how do we monitor and continuously improve upon our practices. Now, when we look up these standards as far as this concept of risk is concerned, we would notice that there are a lot of safety standards and related standards which have been published, which directly or indirectly talk about this concept of risk. starting from the Department of Defense, which published a document which is called as MIL-STD, or an ISO Guide 73, or the CLSI guideline. Now, why did we have all these coming up? Now, there are two scenarios which were quite famous. In one scenario in Canada, a lab actually introduced a new molecular test without actually functionally validating it. And this led to many false positives and false negatives, leading to wrong diagnosis, poor treatment decisions, patient deaths. And then it led to an official public inquiry, and billions of dollars were spent and reputations were permanently damaged. Likewise, in the UK, a lab used a new test with known very poor specificity, which is for both the testing and screening, which led to many patients being incorrectly identified as having sexually transmitted infections, and there was patient harm from resulting from this information release, and the patients sought redress through litigation, and community reputation was harmed. So these are all not just isolated international incidents. We do have similar incidents in our own practices, and they are all failures in what we call as failures in managing the risk. Now, we understand what is called as the ripple effect. Now, what is ripple effect is how small causes or how small changes can lead to very big consequences. You can see in this picture, for example, a technologist sneezes, and another technologist is distracted by it. A wrong entry is made in the keyboard, and the wrong patient's test sample is tested, and an impending renal failure is missed, and the patient dies. So what started as a small event led to a totally disastrous consequence, which was never anticipated or never even expected. So these key concepts from this chaos theory, where the cause and outcome may be non-linear or maybe non-proportional, and the greater the interval between the cause and the effect, the less likely the relationship is getting recognized. So bad thing is happening. We cannot stop bad things from happening. Our goal is not to predict every event, but to build systems which are resilient enough to limit their occurrence is what we have to understand as far as this concept of management is concerned. So in this, we will be repeatedly hearing some terminology. So let me clarify some of these terminologies. The first terminology is what is called as a hazard. Hazard literally is a source of a potential harm, and it is not a harm itself. For example, an expired reagent, an untrained technician, a faded label, an uncalibrated analyzer. All these are potential hazards which have not yet led to the next one. What I'm talking about is the harm. The harm is the actual adverse outcome which is happening because of this. For example, a wrong diagnosis, a wrong treatment, a delayed care, unnecessary therapy. All these are harms. So we have a hazard and we have a harm. And that brings us to the word which we are going to discuss today, that is risk. So risk is a word which is basically derived from the Latin word riscare, which means to dare. So what are we daring here? The risk management, in one of the books it is mentioned, risk management becomes a reality when humans realized that they could dare the gods and aspire to their own goals. In the book Against the Gods, this was written. So what are we daring and what are we trying to change? The concept of risk is perhaps not really new. We have risk in possibly every sector what we could. If there were no early seafarers, I don't think if Columbus had taken the risk, we wouldn't have discovered land masses across the globe. Airlines take risk, transportation has risk, gamblers and investors have risk, finance has risk. Every possible sector has risk. So the concept of risk per se is not new, but it is slowly coming into the healthcare sector, which started in the 1970s and then went on into patient safety programs. And later on, it trickled down even into the medical laboratories when they realized risk is the real threat. And as I said, there are plenty of international standards which have been published in relation to this risk. And some of them are very, very relevant to us. For example, the technical document that is 22367-2020, which is for the medical laboratories, which where there is application of risk management to the medical laboratories, is one of the important documents which I'll be utilizing to discuss today. And we have related ISO standards like ISO 31000 of 2009, 31010 of risk management, etc. So how do I define this risk? The core definition comes from the ISO 31000 definition, which says Risk as the effect of uncertainty on the objectives. What is the uncertainty of an objective? I buy a lottery. I am buying the lottery with the objective of winning that lottery. I may win, I may not win. So I'm taking that risk. The risk is I may get a $1 million or I may lose that $50 from my pocket. Both are possible here. So the effect can both be positive or negative. So the risk includes both potential threats as well as potential opportunities related to the objective. So in the example, what I told, I wanted money. That was my objective. I may end up losing money or I may end up gaining money can be the effect. So risk is always defined in relation to its objectives. The objective could be a strategic objective, it could be an operational objective, it could be a clinical objective or a financial objective, and it is never talked about in isolation. So the uncertainty, what we are talking about, it refers to the possibility that the actual outcomes will differ from what is expected. I take a risk, I expect a lottery to be won, but I may or may not win. So the outcome, what is expected, may turn in either direction, which is why the standard explicitly treats risk as an uncertainty that matters for achieving objectives. So that is the definition which comes from ISO 3100. Now we are talking about the medical laboratories, and the standard for the medical laboratories, as we all know, is the ISO 15189-2022 standards, which talks about its risk. If you look at the 2022 standards, it clearly talks about both the risk management and also it talks about, how are we going to address those risks. An entire section 5.6 is listed for risk management. And this ISO 22367 will tell us how to get going with this risk management. So technically, both these standards are, you can consider them as partners. Together, we can have one integrated, quality management system, which aligns itself to any accreditation standard, be it a CAP or a CLIA or a 15189 accreditation standard. So this one ISO 22367 system, it practically satisfies all the three frameworks, be it CAP, which talks about quality procedures and risk file, or the CLIA, which talks about the QCPT or monitoring data, or the ISO 15189, which talks about the risk-based thinking, which is built into the standard. So in result, you get an integrated single quality management system. So as I said, when we talked about the risk, it's a combination of the probability of the occurrence of the harm and the severity of the harm. So we know that there are knowns and we also know there are unknowns. So there are known knowns, there are known unknowns, and there are also unknown unknowns. So there are things we don't know yet. That's said Donald Rumsfeld. And we know that risk, as you can see in this picture, could be measurable, it could be immeasurable, or it could be totally uncertain. So our calculations are always incomplete. We must plan for what we can measure and be diligent for what we cannot foresee. Both are equally important. Now, this whole concept of risk and risk management has shifted the paradigm. In traditionally, we used to say, oh, there is an error which has happened. But now we are talking in terms of this concept of risk management, wherein it's a systematic process. Any process has an input and an output. This 22367 2020 ISO standards provides us a systematic process for medical laboratories to identify, estimate, evaluate, control, and also monitor the risks which are associated with all the aspects of the laboratory examination. And this has become one of the standards to look up for, which we'll be briefly trying to understand in today's webinar. It applies to all the examination services. It's not just for the test. It includes the pre-examination, examination, and the post-examination process. And hence, it is designed to be integrated with existing quality management systems. That's why I said 22367 perfectly aligns with ISO 15189 to create a holistic culture of both laboratory safety and, in effect, the patient safety. So the key objectives of this standard basically is to manage risk to patients, the laboratory workers, the service providers covered with medical laboratory examination. And this standard does not talk about the business enterprise risk, which is covered by the ISO 31000. So why should risk management matter after all? Every lab test is guiding the patient care, and any error is a potential harm. So risk management is basically getting proactive. It's not just randomly doing something. We are doing something systematically. we are doing something evidence-based, and we are not doing for one time, we are doing it continuously. So the goal is to prevent the errors even before the patients are ultimately harmed is the ultimate goal for the risk management. So as I said, it all boils down to the uncertainty to finally assuring the quality assurance through the 15189 accreditation standards, which we talk about. This is how a risk management is done. We will look into it. So the key aspects of this ISO standard, which aligns to the patient safety, is what I'll be discussing shortly. Now, when we look at the process for this risk management, broadly, it is categorized under 5 headings. One, we have to plan and assign responsibilities. Second, we'll have to do a risk analysis. Thirdly, we'll have to evaluate that risk. Fourthly, we'll have to control that risk. And fifthly, we'll have to monitor and review it back. So these are the 5-phase risk management process, which keeps happening in a loop in every aspect of the laboratory process. So if we have to do something like this, there has to be commitment, and that commitment comes from the top. The commitment comes from the top management. So the effective risk management begins with a demonstrable commitment from the laboratory management. It is not a passive role. It involves active engagement in defining policies. You'll have to provide resources, and it ensures this process effectiveness. So the clauses of the standard, especially the clause 4.2 and the 4.3, will talk about the management responsibilities and the personal responsibilities as to who defines who is going to make the policy for the risk management, who allocates these resources, and it must be done by personnel who are aware, who have appropriate knowledge and experience to understand the various laboratory processes, and that must align to the need of the laboratory. Following this, we'll have, after we identify the risk, next, we'll have to plan the risk management plan. So before the actual analysis begins, a formal risk management plan must be established for each examination procedure or service. Remember, each examination procedure has a pre-examination, examination, and post-examination. So this plan will guide us a roadmap for all the subsequent risk management activities, which is as defined in the clause 4.4 of the ISO standard. And the scope must be proportional to the risks which are actually considered to the relevant examination. So as I said, first one, we'll have to plan and assign responsibilities. First, you will have to understand what is the scope of work. You may be doing several things. You may be doing several tests. You may be doing several procedures. So first, you will have to understand what is the scope of your services. You will have to make your core team. You will have to assign roles, who is going to do what. And when it comes to risk, you will have to set a standard. This is what I'm going to accept, or this is what I'm not going to accept. I'll have to build in timelines and also give resources for the same. And when I make this, I should have it in the form of a plan, which should be authorized. So we have a signed risk management plan. So following this risk management plan, next starts the main activity, the core cycle, which involves the risk analysis, the risk evaluation, and the risk control. At the heart of the ISO standard 22367 is a dynamic 3-part cycle. This is where the potential harms are systematically identified. It's not just randomly identified. You understand the significance of each of these harms. Their significance is judged against an existing established criteria, and you're measuring it and to implement to reduce this risk to an acceptable level. So when I say risk analysis, you're trying to tell what can go wrong, why it is going wrong, and what are the consequences. When I'm doing risk evaluation, I'm estimating the risk acceptable to the laboratory's policy. And risk control, if it is not done, what actions will we be doing to bring down that risk? We may not be able to eliminate that risk entirely, but we must be able to do some actions to bring down that risk. So we have risk analysis, risk evaluation, and risk control. So in risk analysis, as I said, we are identifying what could go wrong. As I said, again, we are doing a systematic use of what? All the available information related to the scope, which may cause a potential harm. And we are going to document each of them. So the process must be documented for each examination procedure. So first, we have to identify the hazard. Remember the definition what I told for hazard. You have to document both the known and the foreseeable hazards. For example, it could be a equipment failure, you could have a faded label, etc. Second, you will identify potentially hazardous situations. For example, for each hazard, consider the sequence of events that could lead to an exposure. An incorrect result is a hazard. A clinician acting on that incorrect result is a hazardous situation. Thirdly, you identify foreseeable harm. For each hazardous situation, identify what the potential harm that could result. It can result in an incorrect diagnosis. It can cause a delay in the treatment. It can cause an adverse event. Any of them can be happening. And you will have to document the severity of each of these potential harm, which I'll be coming to in a while. So the key principle here is the risk analysis. We are estimating the risk, which could be qualitative and quantitative. But please remember, it must consider the entire process. So if you have a given laboratory test, it should indicate the risk analysis should be done for its pre-examination, examination, and the post-examination process, not just individual components. So here we identify the hazard. For example, an equipment is improperly functioning. So you have a probability of a hazardous situation occurring. For example, if the foreseeable sequence of events, if you take, for example, here, a point of care testing glucose analyzer, this battery may be reaching an end of life. Right now, it has not caused any problem, but it may cause a problem. And what that problem could be, it could erroneously give a result, or a hypoglycemic patient may end up receiving a falsely elevated glucose result because of this malfunctioning of this device. Because of this hazardous situation, what it led to the harm. It led to the inappropriate insulin administration, and it led to even death of this patient. So overall, you have a probability of this occurrence, and you will also have the harm which is happening, which we ultimately quantified as risk. So this is the path from the hazard to the harm, which we should be understanding. So how do I do this hazard identification? We use a checklist, what is called as the PERMS CSI checklist. What is this PERMS CSI checklist? P stands for personnel, E stands for the equipment related to that procedure or process. The reagents involved are R, M is for the materials which are used, S is if there is any software involved, C is for the communication. How are you communicating these results? Are there any supply chain issues related to the reagents or the equipment? And the interfaces. So all of them can be a potentially hazardous situation. So we brainstorm almost 15 to 30 hazards for every process systematically. We try to see the sequence, what may happen. As I said, it leads from a hazard to a harm, and we are trying to break the chain anywhere which can finally help us reduce the risk. So as I said, for any laboratory process, we know the laboratory's risk footprint exists across the pre-analytical, the analytical, and the post-analytical phase. In the pre-analytical phase, there could be lack of information requirements. For example, the sample requirement, they may not know what is the tube type, how much centrifugation should have been done. There may not be no patient instruction relevant for the test, or there could be improper sample transport condition. In the analytical, there may be no formal plan for analyzing the quality. There may be failure to follow the manufacturer's instructions as far as equipment maintenance is concerned. There could be failure to follow the regular calibration procedure. There could be limited understanding of the quality control theory and application, or there could be even poor communications between the shifts when they are continuously analyzing tests. And it could be post-analytical. When the results come, somebody has to verify whether this result can be released or not. A result validation performed without knowing the key background from the testing technologies could be a harm. There could be increased transcription errors if you do not have an inbuilt LIS system and somebody is manually typing it, or if there is a problem with the LIS or the QC software, or somebody is not regularly reviewing the QC data retrospectively also, or failure to establish or compare reference ranges across instruments, all could be a possible source of this risk. So where do I get all these possible risks to identify all these hazards? You can get from the IFUs, that is the instruction for use of the manufacturer. They may be giving technical bulletins. You may be getting these hazards from your communication with your patients or your clinicians who may be giving you feedback. You may be getting these from your QC records or your calibration or your maintenance logs. You may be getting them in your internal lab meetings where one team member or your lab technician is raising some issues which you know is a potential hazard. This may come up during your internal audit findings as non-conformances, or this may even land up to you during your external quality assessment, either during your proficiency testing or a third-party audit like your 15189 accreditation. So in any one of these places, you may end up getting these potential hazards. to the extent possible, reduce the surprise by getting as much information as possible. After knowing what are the hazards, next I have to know how to analyze those hazards. And there are various tools which are available to do the job. One of them is what is called as the failure mode effect analysis, wherein every single step is considered every way it could potentially fail, and we develop alternative strategies for each potential failure. There is a thorough, systematic, and lengthy and a detailed analysis for each of them. It is best used in a setting with a lot of information and control. One of the commonest tool which we use in the laboratory is what we call as the SO grade, which is nothing but your severity occurrence grade, which I'll be stressing upon. Here, it will be focusing on two major issues, that is, how terrible the outcome can be, and secondly, how frequently would it occur. So we will understand when we take with practical examples. So we will focus this as a practical tool to understand the risk management. So one of this SO grid came up in one of the standards I already mentioned related to the the defense document MIL STD, where they put up in relation to how severe a harm or how severe a risk could be and how frequently it could be. And you could see the color coding starting from red to orange to gray. The red being category 1 and 2, which says catastrophic and critical, which led to death or permanent total disability or loss of a quantifiable amount, or it is critical, which led to permanent partial disability or hospitalization or even loss, or it could be marginal or negligible. When you talk about occurrence, something which is happening frequently is marked as red, or probable is which will occur several times in an item's life, or it could be occasional, or it could be remote, or it could be improbable, so unlikely that it may not be practically experienced at all. So this is the baseline for making this SO grid in relation to even your medical laboratories. So as I said, we have to evaluate the risk. The next step was, after identifying the risk, we are evaluating the risk by judging the significance. Once a risk has been analyzed and estimated, the laboratory must decide then whether it is acceptable, if the risk reduction is required against the risk acceptability criteria, which the laboratory must establish, approve, and document in its own criteria for acceptability. This is based on the risk management policy, the applicable regulations of the local guidelines or relevant standards, and it should also take into account generally the accepted state of art, and it must be approved by the top management, which it could include the laboratory director in case of the ISO 15189. And each risk has to be evaluated, as I said, for each hazardous situation, apply the approved criteria to estimate the risk, if the risk is acceptable or if it is unacceptable. So if you will see here on the left side, you have the severity of the harm, which is from negligible to critical, and we have the probability of the harm, which is coming from unlikely to frequent. So all this in the lower left is all in green, and all this in the upper right is all in red. So something, if I am identifying a risk which is happening very frequently and it leads to a lot of damage, can be put up in the topmost category in the red. Whereas something which is happening remotely, maybe once in a year something happens and it has no much significance on the result or harm, would be unlikely. So for every single process, you will have to understand the probability. So the green would be unacceptable, the amber is tolerable, and the red is unacceptable. So who decides is acceptable, unacceptable? That policy has to be clearly defined by the laboratory against its own risk acceptability criteria. So all the greens are low, all the orange ones are medium, and the red ones are all high severity. So you have a matrix which basically provides a visual method to rapidly assess and prioritize the risk. What is it prioritizing? It tells us the potential impact and the likelihood that it may end up causing a harm in the patient. And based on this, even the authorities are also accordingly assigned. So something which is the very highest risk, let's say, which is bound to affect almost everybody, the person to take decision will be somebody like a higher up, like a minister, or it could be a health authority, or it could be your institutional CEO. Whereas something which is very, very low could be handled up by your section in charge or a section lab head, or something in between could be handled by your departmental head. So the decision making is also aligned to this. Higher the level of the risk, the higher the decision level, and lower the risk level, the more delegate the decision level. So what are the key factors which actually impact this decision? One is the safety, cost, and the liability which you may face, the confidence and reputation of the organization, whether there are any alternative choices, and if you can mitigate that risk, or you could possibly end up sharing that risk. So if you make a risk matrix with this SO grid, the attempt is not just making this graph and keeping it, to also act upon it. That is what is called as risk mitigation. What am I doing is, risk mitigation is about implementing specific risk control measures to move risk from an unacceptable position on the grid to an acceptable one. Suppose you would have identified a risk which comes somewhere in this medium zone. You should put in control measures so that it comes down from 3 to 2 or even 1, and from the orange region, it should be come down to even the green region. So that should be your strategy to mitigate that risk, and that has to happen for each specific test as required. So this estimation of how severe the risk is what we call as the probability and the severity. The probability is, has it happened? Are there controls already? And severity, is it a reversible or irreversible thing which has happened? Has it caused treatment delay? Has it affected vulnerable patients? And you have to document justification for each score. Usually we give it in the form of a score wherein the risk is a product of probability and severity. So on a probability, if I have a score of 1 to 5, and a severity, if I have a score of range of 1 to 5, which ranges from remote to very high or negligible to catastrophic. So you can have the scores of the risk ranging from 1 into 1, that is 1, to 5 into 5, that is 25. So this is how you quantify that risk, whatever you are trying to look into. And this risk matrix could have color zones, wherein the greens are the acceptable or monitor only, the yellows needs controls, and the reds are totally unacceptable, which requires a major action. And you can segregate the scores also. Let's say 1 to 6 is green, 7 to 15 is yellow, or 16 to 25. This you will have to define for your set of laboratories, for your own set of practices, and must be signed off by your own laboratory director or top management. What control am I going to do? We are going to do the PDC control. One, can I prevent? You have to stop the hazard from occurring. Second control, can I detect? You should catch the hazard before even the patient is harmed. And third level of control is, yes, it has harm. Can I correct it? To limit the harm if the preventive and the detective layer is failing. So you will have to think of the controls for every risk in preventive, detective, and corrective practice. And the best practice is a layered defense, which tries to have a combination of all of them. And finally, as I said, once you have all the risk does not vanish away. You will still have something which is what is called as a residual risk. So if after all the feasible risk control measures are implemented, the residual risk is still not judged acceptable, the laboratory must conduct a formal analysis to determine if the medical benefits of this examination outweigh this residual risk. So you will be implementing various risk management strategies or risk control strategies. And finally, you will try to evaluate, as my strategy work, and then I will look at the benefit and the risk. And based on the benefit risk analysis, I will also understand how much this risk has been mitigated. So finally, after having done all that, we will have to review to confirm whether this overall risk which has come now is acceptable or not. So before releasing the results from the examinations covered in the plan, a comprehensive review of the entire risk management process must be conducted. Then we know that the risk management plan has been implemented in total. So the risk management plan has been appropriately implemented. All potential hazardous situations have been considered. The overall reduced residual risk is acceptable. And finally, this is recorded in a risk management report that the plan has been satisfactorily fulfilled, and it confirms to the overall residual risk, which is acceptable and which is approved by your laboratory management. So, as I said, the residual risk, it controls rarely eliminate the risk. They reduce it only to an acceptable level, and that acceptability is what you have to define for your laboratory, for your processes. And what do I document it? I love to document it in what we call as the risk file. So what does it have? One, you have your hazard registers where you have identified all your hazards. Then you have done your risk analysis. As I told you, you can use scoring. You will have to evaluate those risks. You'll have to decide what you have to do for those risks. You will have implemented control measures. You will have to show evidence for those control measures. Then again, you will have to follow up by looking, is there any residual risk is left? And you will have to monitor those records. And there has to be a management review of these records, which is dated, signed, and audit ready. That makes your entire risk file, which is auditable. So as I said, after you have done the risk assessment, risk mitigation, and risk control, you don't stop it. You will have to keep monitoring it. So that is the last phase wherein the monitoring and continuous improvement is concerned. So you keep a target or you keep an indicator which is measurable, wherein you keep an acceptance limit and you decide how frequently you are going to monitor. I'll give you some examples for you to understand. So you may monitor it something daily or a weekly or a monthly basis. And if something is deviating, you may be investigating it. For example, for QC pass of more than 99%, or I should have less than 2% specimen rejection, or there should be less than 30 minutes for the critical results to be, informed. All this could be criteria which the laboratory may define on its own. So as I said, it's not just defining that risk and making a plan and making an SO grade. You will have to maintain vigilance. Risk management is not a static process. It is a continuous process of vigilance wherein the laboratory must establish a surveillance procedure to collect and to analyze the information about its examinations throughout their life cycle. So the key surveillance activities are based on the risk-based triggers and the action alerts for timely response to any such events, and to determine if any unanticipated hazard has occurred or if the estimated risk for a situation is no longer acceptable. And again, where am I going to get all this information? You may be getting from internal sources or external sources. You may be getting an EQUAS, which is an outlier. Your physician may be complaining, look, I'm getting a report which is not in consonance with what is going on in the patient. I may be getting notices from the manufacturer which says, you will have to modify the examination procedure like this, or there could be regulatory authority alerts, or there could be literature reports or even accreditation body audits which tells you that something has come up. Or it could be from your own internal monitoring like your QC data or your incident reports or your internal audits. So this process is not a static one, it is a continuous one. Many of you may not have done even a risk management program, and it is worthwhile that you start realistically and not rush something through it. So you will have, you can keep a good 1 year to look up at this program where in the first month you plan and then you assess and you design your risk management plan. You implement and train everybody to align yourself with the risk management plan. You verify what is happening, and then you go on to the second process and you continue doing this every year, and by at least 1 or 2 years, I think the system will be robust to have a culture, and you can even face audits very, very confidently. So the 8 core concepts what we learned today was, one is the risk identification, risk scoring. We learned the 5 phases of the cyclical process. We learned the PERM CSI for the hazard hunting. We learned layered controls, and everything has to be documented and monitored with meaningful defined indicators from the labs. And it should meet the CAP or the CLIA or the 15189 accreditation requirements, depending on what your standards you are applying as far as accreditation is concerned. And you color code to fix the risk and monitor them accordingly. So, for example, you could pick a high risk and review templates in week 1. You could assemble your team and make the PERMs brainstorm and score risk. And you define the top 3 controls, what you want to do and implement. And week 4, you complete the risk file and staff briefing. So 1 full risk assessment is concerned. So you can start small and aim big. Always be open for discussion with your team, because nothing is perfect. Any concept which your lab specifies or requires may be having implementation problems or regulatory compliances issues also. Take help from the resources like your 22369-2020 standard. You can have templates, you can make your own checklist, and you can have a plan which is meant for protection, not for punishment. You're not going to bring anybody to task that some bad event has happened. Rather than you take it as an opportunity for improvement and thus committing yourself to patient safety. Some quick examples for some of the possible scenarios. For example, in microbiology, the hazard identified was the new media supplier was not validated. and the media was contaminated. And as a result of which there was a false positive blood cultures. So false positive blood cultures leads to unnecessary antibiotic usage for the patient. So we had an original risk, which was 2 into 5, which was defined as yellow. So 2.2 into 5 was 10. Then the controls were introduced. What are the controls? We used the pre-used validation technique, and we also ran a negative control. And the residual risk now became from 2 into 5, became 1 into 5 and went into the green zone. So that is how you identify a hazard and you control the risk and bring down the risk levels. In hematology, the hazard identified was there was a calibration drift which was undetected, which led to wrong patient counts which are going. So the original risk was calculated as 2 cross 4, which was 8. Then a layered PDC controls. That means every day somebody has to run the controls on time. Every day somebody has to check this controls on time. So the PDC controls were introduced, and the residual risk will come down from 2 into 4 to 1 into 2. So it goes into the green region. In biochemistry, hemolysis was leading to false potassiums in the patient, leading to unnecessary critical care management of these patients. A simple approach is visual, that is visual instrument automated reflex. Before you even load the sample, you would have checked for hemolysis, leading to unnecessary, scare among the clinical people. A simple visual approach would have brought your things under control and hence bring down the residual risk. In histopathology, it could be a specimen misidentification. So you'll end up giving a cancer report to the wrong patient. So imagine the risk will be very high. In almost the score is coming to 10 in the red zone. So you will have to do a 5-layer control to residual risk to bring it down to as low as possible to 0.5. This 0.5 or 1 has to be defined by that particular lab. So it's not just identifying the risk, you will have to quantify the risk and monitor the risk after doing the specific risk control. Some of the examples I can quote, let's say from the clinical pathology department. So we had the process of urine sample collection. So the risk identified was there could be a potential contamination of the midstream urine sample. The relevant ISO clause was put. The probability was thought of 4 and the intensity was 3. So total score was 12 and it went into the medium category. And what control measures because of this risk? We are putting patient education leaflets, sterile containers are made available, verbal instructions are given to nursing staff in the inpatients, and also pictorial guidelines are there. Who is the person responsible for these control measures? The persons in the nursing staff or the persons who are in the sample collection. But how am I monitoring this? I have to monitor the monthly review of the contamination rates. That is the monitoring frequency. So I have identified a risk. I have also assigned who is going to responsible for implementing the control measure, and I'm going to quantify against a target that is a monthly review of the contamination rates. Another one, for example, the high-risk score requires immediate attention. For example, if somebody is giving you an incorrect 24-hour urine sample, I have put a score which is 16 now. So what is the strategy? We have to educate the patient with both written as well as verbal instructions, and creatinine adequacy verification protocol is done. So because something is in the higher zone, I cannot afford to do a monthly analysis. I'll have to keep checking weekly. Am I meeting the criteria of 24-hour samples adequately as prescribed? And how many samples got rejected overall on a monthly basis? So you will have to define and score as per your laboratory criteria, which is high risk, medium risk, and low risk. And as I said, even the responsible authority also starts changing. The higher risk has to be monitored regularly by the lab director or the quality manager, whereas the lower risk could be handled at the level of the quality manager. And what are the monitoring activities? It could be quality indicators dashboard. It could be a risk assessment committee meetings, internal audits, or incidents and non-conformity trend analysis, your EQUAS performance, or your biosafety incidents, or even in your annual management review, wherein the risk profiles are getting updated. And how do I monitor it? I have to make a form wherein I am analyzing each one of this. So for example, if there is a specimen preservation is the process and there is a delay which is causing bacterial overgrowth, I am having a medium risk of 3 into 4, 12. The control measure is put as I have to refrigerate the urine sample within two hours if not processed. Otherwise, preservative has to be added when appropriate, and we should have a timestamp mechanism of acceptance. And this is at the level of the lab technician. I cannot afford it to be a weekly process. This has to be a daily process wherein it is getting monitored. And we can record. I said we have to document it. So I'm doing a weekly review or a daily review or a monthly review. Who's the responsible person? And then you will have a column. Is the risk gone? Then the risk is closed. Or if it is ongoing, it is ongoing. Or the status is closed, it is closed. Who is monitoring it? When was it monitored? And who is verifying it should be documented for effective auditing when somebody audits this respective risk of that particular examination process. So as I said, this risk management has to be integrated into your quality management system. It should not exist in a silo. The 22367 is designed to be fully incorporated into all the relevant aspects of an existing QMS, such as the ISO 15189. The risk-based thinking becomes a foundation for quality, wherein you start looking at supplier management, non-conformities and compliance, audits, change management, design and development, and corrective and the preventive actions. So the solution is a systematic framework for managing risk, where you plan for the risk, you identify the risk, you examine the risk impact, you develop the risk mitigation strategy, and you monitor the risk, and you continue. It does not stop. Just like we have learned in our quality management process, we have the PDCA, plan, do, check, and act in the Deming cycle. Likewise, the risk management framework also has to continuously be monitored. So your first step as a simple exercise you can take up is to find your probable risks in your laboratory. From your last routine internal audit, identify 2 to 4, I wouldn't say risk, maybe you can call it as an opportunity for improvement. Ask for each opportunity for improvement, ask 2 critical questions. What can happen if I don't fix this? This determines the severity. What is the likelihood of a bad outcome? This determines the occurrence. Then make your own SO plot. Plot the potential outcomes for each of these opportunities for improvement. Then you prioritize which one is going to be number 1, which one is going to be number 2, and which one is number 3, which I'm going to address. This simple process turns your audit findings, what you would have done as your internal audit, into a data-driven action plan as far as the risk management is concerned. So you will have to build a culture of proactive safety. The core principles to remember are that the nature of the risk is uncertainty. There will be always unknown unknowns. A risk strategy cannot prevent all bad things from happening, but it will catch and prevent some. Having a risk management strategy will always be better than not having one. And you have to change the culture from hiding errors to communicating problems without any fear of retribution. And risk management is not a one-person effort. It is a team effort. You have to look to the best, but plan for the worst is what we talk about. So when it comes to managing risk, be aware, be sensible, and do no harm to anybody. The destination is a culture and not a certificate. Don't think risk management in terms of an ISO certificate which your lab may achieve. Implementing 22367 is more than a compliance exercise. It is a commitment of your continuous journey for improvement. By embedding this systematic process into a laboratory's QMS, you transform the approach to quality from reactive problem solving to proactive patient safety. So you plan your risk, analyze and evaluate and control the risk, review and monitor, and come back. This structured journey builds a robust, defensible, and effective framework that protects the patients, staff, and the integrity of your laboratory results. Thank you for your patient hearing. I'm open for questions.
You can unmute yourself, whatever your query and doubts you may ask, or either you can drop on chat box also. Do you have any query and doubts from that risk section? You may unmute yourself also.
There's a question, who can enter data in a risk management register? So again, as I said, the policy has to be decided from your laboratory. That means you will make a risk management plan and you will think what is that plan and who is going to do what, all has to be planned at your laboratory level. That has to be approved. And then who is going to monitor and who is going to enter and who is going to be verified is also documented. So likewise, it is not just one rule that one is allowed or one is not allowed. It has to be developed at your local laboratory level is my answer to from Baroda, the question was. I think Dr. Shuchita wants to ask a question. Can she be allowed to unmute?
They
Monish?
can unmute her. We,
She says
they
not
can,
allowed to unmute.
no, now they can
Now,
unmute her. Yes.
Good afternoon, sir.
good afternoon, madam.
It's a very nice lecture. I just wanted to ask something.
Yes, madam.
I did understand the concept of risk that we have to foresee risk and devise it into a matrix. My only query is that are there any objective criteria to calculate the likelihood of a particular risk? How likely is it
Exactly.
to
So,
happen?
for example, how do I know it? It has, I cannot, how do I say it is like, I have a risk of falling, right? I may fall
Hmm.
now or I may fall while walking, but how often I may fall, nobody knows. So I may have a
Hmm.
benchmark. I may say in 2 months, I may fall one time. I may
Hmm.
or may not fall, I may fall more. So you will have to start somewhere to get the data of how frequently something is happening. At least you may be getting from your regular daily NCs or your internal audits. And you will think, okay, this is happening very frequently, so I should keep a benchmark. And then I have to start tracking it and try to bring down that benchmark. So something which is happening for the first time, nobody would know whether it would happen again or it will happen very frequently. But if it has happened and it has caused harm to a patient, I think it should definitely be monitored regularly so that then later on you can monitor it less frequently. So that
Okay.
benchmark is not
Thank you.
defined per se. You have to decide based on your own assessment.
Okay. Thank you so much.
Sir, I
Well,
have a question.
yes,
So, if we are monitoring the risk and only those risks which we require to continuous monitor, that only we need to write in risk management register, or the risk which can arise.
that is what I said. So when you have a risk, you will have a risk which you have identified at the starting of your risk management plan. That doesn't mean that no new risk should come. Um, am I audible?
Yes, sir, you are audible.
Yeah. So let's say at the start of your risk management plan, you had 20 risks which are identified in your monitoring. That doesn't mean the 21st risk should not come. And if it comes, then again, your lab should take the policy of adopting that risk as part of your risk management policy. You will have to define its score. You will have to see how frequently you're going to monitor it. That again, you will have to locally define. So there's nothing like I have done 20 and I'm getting one new risk and I'll see next year. You cannot have that.
Sir, I have one question.
Yes, yes, but
Yeah. Sir, how a severity score will be reduced even if we take risk control measure for that particular risk? And if it is not reduced, then still it will be considered as mitigated? Can you
yes.
please give some example where we can reduce the severity score by taking risk control measures?
Okay, say for example, I'll take an example of a sample getting wrongly labeled. Okay, so if a sample is getting wrongly labeled, that means the risk is low or high.
Yes, it's high risk.
It is a high risk. So what plan would you like to do to mitigate this risk?
So we can introduce some barcoding system, or we can introduce a double check.
Yes. So that is your risk control measure. Now,
Yes.
so your risk was there, and the probability of the identification before you started this barcoding was high, right? So let us say it is
Yes.
a 4 or a 5. So what is the risk which is happening? It will also be a 4 or a 5. So it will be almost 16. Now you introduced a measure that I'm going to do barcoding, but with barcoding, can you eliminate this risk?
No, not exact. I mean, not up to the 100%.
Why you will
But
not be able to eliminate it?
yeah, because again, there could be a chance that a wrong barcode can be
Yes,
stick.
exactly. So barcode is a very good tool, but that doesn't mean that the somebody's drawing may end up pasting the barcode wrongly on somebody else's tube. So, but
Right.
it's not as bad as what would have happened daily when somebody's sample is getting mixed up and all. But it is coming down, but not totally gone. So, what was 4
Yes.
cross 4 might become 3 cross 3 or whatever, depending on you decide what is your score you want to bring down, or you still feel this is also bad, you might end up keeping it at 4. And you have to justify
Right.
why I'm keeping still at 4.
Okay. Right.
So think of your own scenarios and you think this is acceptable. You know, one wrong labeling happening once in 6 months is still bad, but it is still acceptable. You decide, okay, fine. But that
Hmm.
has to be a call from your lab that way.
So again, it will depend upon what current control measures are uh, in practice
Exactly.
based on
If you have a
yeah.
control measure, how do you test its effectiveness is finally whether that harm is happening or not. And if it has
Right.
happened, what harm did it end up doing to that patient there? With all your
Yeah.
controls, still somebody gets a high potassium value reported, then it's definitely going to be a, you'll have to relook at all your control measures. Maybe you have to think of another control measure also.
Right. Right. Yes, sir.
So think it locally at your level and you would be able to.
Okay. Thank you, sir.
Thank you. Dr. Kaushik had a question, how to identify a risk. Is there any tool for it? There is no tool as such to identify. It's what you get. As I said, you will get both from your internal sources, also from your external sources. What are your possible hazards and risks? So you can make it a list. The list can be exhaustive. It can be a small or a large list. You have to start small. That is my suggestion. Don't overdo like 20 risks at a time and you're lost in everything. Start small from your recent NCs, from your daily problems, what you anticipate. Put the control measures, sit with your team, and then move ahead. That will help you, minimize all your risks. There is no particular tool which is better. It depends on what you are comfortable with, and in either way, ultimately, if it is a score, if it is an FME analysis or an SO grade, there is still you're detecting it and you're quantifying it. It is not enough that you say I did an FMEA or an SO grade. What is comfortable for you? No, nobody prescribes that you have to do one particular way. How you do it, you locally define it, justify it, improvise it. No standard says do FMEA or do a SO grade. I hope that answers Ms. Sumida's question. And we use for, I mean, I find BO, the SO grade very comfortable to do. So I am comfortable with that. Dr. Babu has a question. Can you share the PPT? I think, Manish, if you can share, you can share. No issues.
Okay, thank you. So do you have any other current doubts from the risk PPT? Otherwise, we can start with the accreditation process. Then we have one group photograph after this accreditation process PPT. Okay, then, Ms. Geeta, you may continue.
Okay, good evening, everyone. Yeah, let me introduce myself first. Myself, Geeta Kulbe. I'm working as assistant manager in QAI CIA. So now I'll give you a brief about accreditation process for medical laboratory accreditation program. So first, who can apply for the medical laboratory accreditation program? So a medical laboratory implementing the requirements of ISO 15189 is eligible to apply under QI accreditation program for medical laboratories. Now, eligibility for QI accreditation. Firstly, the applicant CAP must comply with all clauses of ISO 15189 2022. The applicant CAB must have participated satisfactorily in the proficiency testing program, that is PT, whatever applicable, conducted by QAI CPT, APIC, or any other national or international accredited recognized PT provider. In case if there is no suitable PT program is available, the CAB can initiate an inter-laboratory comparison, that is ILC, with adequate number of accredited laboratories, or engage into other types of internal quality control checks. The minimum stipulated participation for CAP is one parameter type of test calibration per discipline prior to grant of accreditation and covers its scope in phased manner. It is for entry level. The applicant CAP must have conducted at least one internal audit and a management review before the submission of application. So one internal audit and one management review meeting is necessary. So now the steps to achieve QI accreditation. Applicant CAB is requested to submit the following. Firstly, the soft copy of completed application form that is available in our website. Then soft copy of self-assessment cum management system documentation review toolkit along with reference document. That is our internal document. So all clauses according to ISO 15189 are mentioned. So you have to just go through it that all clauses are implemented. Soft copy of quality manual and quality system documentation. Along with the application form, prescribed application fees to be submitted. Soft copy of signed QACIA 002, that is our terms and condition for maintaining QACI accreditation document. And all the above information shall be sent to the given email ID info@qi.org.in. Now the scope of accreditation. Accreditation is currently given in the following categories, that is clinical biochemistry, clinical pathology, hematology and immunohematology, histopathology, POCT, cytopathology, genetics including molecular diagnostic, nuclear medicine, and microbiology and serology. This is our scope. Now this is the process. First step is like we receive application along with self-assessment cum management documentation review toolkit. This is to be submitted by the laboratory to our email ID. Then review registration and acknowledgement of application. That is to be done by the QACI secretariat, like your dealing officer. Next, third step is document review and quality management system adequacy. That is to be done by the lead assessor, the LA. Then pre-assessment. Pre-assessment is optional. If laboratory opt for it, we can go for it, and that is completely optional. Then final assessment, that to be done by the assessment team. Then review of assessment report by QACI secretary. Then feedback to laboratory and necessary corrective actions taken by the laboratory. Then recommendation for accreditation. This is to be done by the panel of reviewers that give recommendation for further process. Then approval for accreditation by our CEO. Then issue of accreditation certificate by QACI secretariat. And then again, application for renewal that is to be submitted by the laboratory 4 months before expiry of accreditation to complete the whole process in time. Now the fee structure based on the World Bank's income level classification of countries. And for detailed fee structure, kindly mail us to info@qi.org.in. Yeah. If you have any question related to the accreditation process, you may ask. Or you can send your query to info@qi.org.in.
So if you people have any query and doubts related to the QA accreditation process or applications, you are feel free to ask. And I have also shared one feedback form. If you have any query and doubts or feedback for the webinar, please do submit that feedback form.
One quick clarification, I think not seen in the chat. One FMEA analysis, what is the difference between the probability of occurrence and the probability of detection? So as I said, the risk may happen and it may go unnoticed. So how often it is happening is the probability of occurrence. how often you're picking it up. Somebody might not be sending a signed report. It is happening very frequently, but you're detecting it once you check in once in 15 days, then you realize that is a probability of detection. So that is the difference. Sorry, Manish, you can.
Yeah, so if people have any query and doubts, you must still ask. Otherwise, we can have one group photograph. I request everyone to please switch on your camera. If you are okay to switch on your camera, so we request you to switch on your camera so we can have a one group photograph. Okay, then everyone is ready. Please smile. Thank you, Arun. Thank you, sir, for your wonderful session.
Thank
So
you.
we hope you will
AI
go
for this
further.
opportunity, and thank you all for giving me an opportunity to interact with all of you. And I hope I could give some, I don't know, I'm not an expert, but at least what I know, I could explain myself. Can we leave?
Okay, then.
Yeah.
Yeah. Thank you. Thank you, everyone. We can leave the session. Thank you.